Hello, everybody. I'm Dr. Himanshu Mathur. On behalf of Jaipur Rehab, I welcome you all on this such a wonderful day. Although the seasons have changed and the warmth has actually reduced from the days in India, especially. All those people who are watching me from outside India, they must be having a different climate. So the climate has started to change. People have started to relax a little bit more. It's a little cold out there, right? So I'm just giving you a platform, such that more people could get into it, and we can start our mega class for the day, right? So we have a mega class for today. This mega class is attributed to the lumbar spine, okay, the biomechanics of the lumbar spine. Personally, my own favorite topic. So what happened was, when I was studying and I was preparing for this class, I just came across a very interesting fact that if I break this class into Saturday and Sunday that I usually do, so this would in fact break the tempo of the class. So I never wanted to break the tempo of the class. So this was the reason why I took it only for one day, and let today become a little more than 1 hour, and let's break our own boundaries, and let us go to just witness. Let's see how deeper we can go and how much we can think. Trust me, today I'll give you the concepts that you must have never came across. Maybe you might not have came across, right? So we'll be looking today on to very good and interesting concepts of biomechanics of the lumbosacral spine. So without wasting any more time, let us start with this. Let me share my screen, and just a second. Let me share it. Okay, there I go. I hope I'm visible to everybody. So there I go. So everybody know me by now. It hardly matters if you people know me or not, because you must know biomechanics. That is more important, right? So here we are with biomechanics of the lumbosacral spine. As you can see it here, there's such a wonderful, beautiful picture of the lumbosacral spine coming in with 5 lumbar vertebrae which are revolving in front of you, right? They are very strong, very large. It has been because of the place they have been placed, right? So they are meant to bear more load. They are meant to be more stronger, right? The bones here are meant to be more stronger. Okay, so let us start without wasting any more time. So I'll be giving you very brief biomechanical characteristics regarding the structure of the lumbar vertebra. We won't be going into too much anatomical details, as I've told you earlier as well. So the body of the lumbar vertebra is wider, more wider than deep, right? So you can see that the medial lateral diameter of this is too much, okay? Although it is not too much in the length, in this height, it's not that much. The anteroposterior diameter is also not too much, but the medial lateral diameter is too much. You can see it here, the medial lateral diameter here also, you can observe it very well. It is quite available, right? It's quite large here. The superior articulating surfaces, these are the superior articulating surfaces. They are slightly concave and faces medially. As you can see, a small depth here. So they are concave structure and they are facing in. They are facing medially. Okay, they are facing towards each other. On the contrary, the inferior articulating faces, they face laterally. That is, they face away from each other, opposite. All right. Okay, so inferior articulating surfaces, they are slightly convex because they have to articulate with the concave articulating facets. So they are slightly convex. They face lateral. The L5, this thing for the L5, the inferior articulating surface for the L5 is quite flat. Okay, it is more straightened and flat, and it faces anteriorly. It's like this. Because the superior articulating surface of S1 is like this, they face posteriorly. Okay, they are more straightened and flat. Okay, they are not concave or convex. All right. Now the spinous process is strout and rectangular. The transverse process is slender and it projects laterally. You can see it here very well. It is projecting laterally. The vertebral canal is triangular and it contains chorda equina. Okay, you can see it quite evidently here, right here and right here as well. Okay, so these are the structures that we have to talk about today. Kinematics, if I talk about, there's 3 degrees of freedom available. Let me write it down here. 3 degree of freedom. It moves in all sagittal plane, frontal plane, and horizontal plane. So flexion and extension occurs in sagittal plane. Almost 50 degrees of flexion occurs, 15 degrees of extension occurs, and almost 65 degrees of total sagittal plane motion occurs. अच्छा, हमको कई बार सुनकर के ऐसा लगता है या देख करके मूव करने में ऐसा लगता है that more amount of lateral rotation is available at the lumbar spine, but it is quite less as compared to the thoracic spine as well. So only 5 degrees of movement is available. So 5 degrees of movement in 5 segments. So you can say that nearly 1 degree of lateral rotation is available at every lumbar segment. Okay. Talking about the lateral flexion, so only 20 degrees of lateral flexion, that is the frontal plane motion, is available, only 20 degrees. Okay, so in 5 segments we have 20 degrees. So nearly, if you try to divide it, you can say that 4 degrees of movement is available at every this thing. Okay. Now coming on to the arthrokinematic changes of the arthrokinematics. Let me write it here so that everybody who's joining us. Arthrokinematics. So if I talk about the arthrokinematics, we have talked about this a lot of times. It is quite similar to as of in the typical cervical vertebra or the thoracic vertebra also. Fine. So if the vertebra is like that, or if the inferior facet of the superior vertebra is like this, and I'm rotating like this. If I'm rotating to right, then the that on the contralateral side would go into approximation, and that on the ipsilateral side would go to distraction. Okay, so more articulation, more approximation here. Okay, so more articulation and compression on the contralateral side, and more distraction on the ipsilateral side. So if I am turning on the right side, it is the right side facets which are going away from each other, and on the left side they'll be coming towards each other, right? So the ligaments available on the right side, especially the intertransverse ligament, the capsule of the zygapophyseal joint, could be the ones that would be restricting this motion. Okay, so as I told you earlier also, only 1.1 degrees of unilateral axial rotation is measured between L3 L4, which is probably the highest amount of flexion, extension, highest amount of lateral rotation which is available at any joint. Okay, that is 1.1 degrees only. Okay, near sagittal plane orientation of the facet blocks this rotation. Okay, because I forgot to tell you about the orientation of the facets also. So I'll go to the first slide back again, and the facets are oriented at 25 degrees from the sagittal plane. Okay, from the sagittal plane. All right, facetal orientation. I shall write it. Okay, so the facets are oriented at 25 degrees from the sagittal plane. Okay, so if I now try to commemorate all the orientation of cervical, thoracic, and lumbar spine, so 45 degrees from the frontal plane, cervical spine, 15 degrees from frontal plane is your thoracic spine, 25 degrees from the sagittal plane is your lumbar spine, right? So this is how you can remember it. It is easy to remember it in this way. All right, coming on to the sagittal plane kinematics. Sagittal plane kinematics is again same as we have already talked about in our previous lectures for the typical cervical spine and your thoracic spine. So the moving surface will always be the inferior facet of the superior vertebra. So whenever I'm going into flexion, the inferior facet of the superior vertebra is going superior and anterior. Whenever I'm coming back into extension, so they are coming posterior and inferior. So as soon as in flexion, if they are going superior and anterior, the surface of articulation is being reduced. Okay, there is a reduction in articulation when I am going into flexion. Okay, so there is more compression onto the anterior aspect of the disc. There is a relaxation, relative relaxation onto the posterior aspect of the disc. There will be more stretching of the zygapophyseal capsule posteriorly. There will be more stretching of ligamentum flavum Ligamentum flavum will be one of these structures that will be restricting this motion. I am not taking the classical ligaments right now because I've already talked about ligaments in my previous lectures. I'll be putting up with the link in the description for the ligaments, because we have already talked too much about it. In our last, say, 3-4 lectures, we were talking about that only. All right. So whenever I am going into flexion, there will be opening up of a neural canal or neural foramina. There will be opening up of neural foramina in the flexion. Whenever I'm coming back into extension, there will be stretching of the anterior longitudinal ligament, you can say that. There will be compression of the disc from posterior side, and the neural foramina will close. Okay. Now let us see what they have to talk about. All the things that I have told you is written in the first few these points. Okay. Now let us see the second last point. In healthy backs, passive tension in the apophyseal capsule reduces the compressive force on the intervertebral disc, whereas reduced force from the capsule in weaker backs can be potential reason for disc injuries or displacements. So always remember, अगर मेरे zygoapophyseal joint का posterior जो capsule है वो weak है तो हमेशा ज़्यादा force anterior disc पे आएगा. लेकिन अगर मेरा पोस्टीरियर कैप्सूल की टेंसाइल स्ट्रेंथ स्ट्रांग है, ज्यादा है टेंसाइल स्ट्रेंथ, तो वो कभी भी एक्स्ट्रा लोड मेरी एंटीरियर डिस्क के ऊपर आने ही नहीं देगा. अच्छा, अगर एंटीरियर डिस्क पे ज्यादा लोड आएगा तो वो प्रेशर के कारण से न्यूक्लियस पल्पोसस जोर से पीछे जाएगा. अगर जोर से पीछे जाएगा तो जितना ज्यादा फोर्स होगा उतना ही ज्यादा फोर्स से वो पीछे भी जाएगा, तो एनुलर फाइबर्स टियर करने लगेगा. तो दिस विल कॉज प्रोलैप्स इंटरवर्टेब्रल डिस्क और एनी सॉर्ट ऑफ क्या कहना चाहिए, डिस्क डेसिकेशन कुड बी देयर. राइट. नाउ टॉकिंग अबाउट इन फुल फ्लेक्शन, the foraminal diameter increases, the IV, it's not four. This the intervertebral foramina diameter increases by 19% and the volume of spinal canal increases by 11%. So if my neural foramina is like this, or the neural foramina intervertebral canal, I would say, if the intervertebral canal diameter is increasing by 19% here, okay, this way, if it is increasing, so in cases when I have say this spinal canal stenosis where the intervertebral canal diameter has reduced, I can ask for the patients to go for flexion regime exercises, and I can attain postures which would rather make the spinal canal, or which would rather give the spine a flexion posture, right? क्योंकि flexion posture अगर मैं करूंगा तो flexion posture से intervertebral canal का diameter जो है वो बढ़ रहा है और volume जो है वो भी बढ़ जा रहा है. ठीक है ना. तो जो पेशेंट्स को सिम्टम्स आ रहे हैं स्पाइनल कैनाल स्टेनोसिस की वजह से वो रिड्यूस हो जाएंगे वहां पे. राइट. Okay, this is something what I needed to tell you. You can see that this is the inferior facet of the superior vertebra. In flexion it is going superior and anterior, and in extension it is coming back posterior and inferior, right? So you can see it here, you can see it here also. And this was a very small, beautiful video I just saw, so I thought I should share it with you. Right. So this is something what you need to learn here. Coming back to the extension of the lumbar spine, I've told you. So the second last point suggests you full extension increases both amount of load and area of contact of the epiphyseal joint. We all know about it, right? क्योंकि वापस पीछे आ रहे हैं, पीछे आएंगे तो contact area हमेशा बढ़ जाएगा, और जैसे मैं extension में जाऊंगा तो line of gravity will also be shifted posteriorly, so the weight which is coming onto the facet joint will also increase, enhance. Okay. Coming back to in full extension, the intervertebral foramina diameter reduces by 11%. And volume of spinal canal reduces by 15%. Okay, so all those people who are having spinal canal stenosis must avoid the extension position, because if they will be avoiding the extension position, in that case only they will be having a reduced pain. Otherwise, extension position will give them enormous pain. Pain will enhance for those people. Okay. Talking about the lumbopelvic rhythm. Okay, there's some glitch with the thing going on. Just a second. Okay. So when I talk about the lumbopelvic rhythm, Now, what is lumbopelvic rhythm actually? Lumbopelvic rhythm is the pattern of getting down into forward bending and coming back. So the body that follows, or the spine and the pelvis that follows a rhythm by working compensatory. Okay, they have a compensatory work. Whenever I have reduced movement at the lumbar spine, then hip joint or the pelvis would compensate for this. And if in case I have reduced motion at my pelvis or the hip joint, more flexion is attained by the lumbar spine, right? But the lumbopelvic rhythm is not just this. Now, how do we start with the lumbopelvic rhythm? We start by getting slouched down. Okay, after getting slouched down, I just bend my neck forward and then I start bending my trunk. I start bending my lumbar spine or start flexing my lumbar spine. Now, all these work which is happening, it is not because of the abdominals. Although abdominals are the flexors of the lumbar spine, but this work is being done by eccentric activation of the erector spinae. Okay, eccentric action of erector spinae. All right, so it is being done by that. So always remember this one important thing, that whenever I'm bending down, it is not my abdominals which is taking me down, it is the erector spinae which is taking me down. Okay, so when I start bending, start flexing my lumbar spine, because of the eccentric work of the erector spinae, I start going down. Eventually, it is followed by the anterior tilt of my pelvis and simultaneous flexion at my hip joint, right? So now this point comes that I have written over here, that is the act of bending forward while keeping the knees straight. It involves 40 degrees of the lumbar flexion and 70 degrees of the hip flexion. Okay, so whenever I get down, after I say there is a simultaneous flexion at the lumbar spine, anterior pelvic tilt and hip flexion, I start getting down. Before I reach completely down, the pelvis start tilting posteriorly because of the stretch or the tensile strength coming, or the what you can say, the length shortage that is coming into the hamstring muscles. Okay, because of that, my pelvis start rotating posteriorly, start tilting posteriorly. Now, when I am into complete bending position, when I have bent completely down, it is a position where your erector spinae stops working. The whole load of the upper body lies onto the tensile strength of the ligaments. Now, if in that stage, I'll just tell you in the figure, if in the complete bending stage, if I go for EMG of erector spinae muscle, there will be no activity observed in the erector spinae. So this phase is known as phase of electrical silence. Okay, phase of electrical silence. All right, so you can always remember that whenever I'm into complete bending position, bent position, in that case my erector spinae stops working. Okay, and the whole load relies onto the tensile strength of my ligaments. Okay, that is known as the phase of electrical silence. Now, what happens is when I try to come back by the action of erector spinae, because of the electrical silence, my erector spinae are not working. क्योंकि वहां पे एक्टिविटी नहीं है, तो मेरी इरेक्टर स्पाइने मुझे पुल बैक नहीं कर पाएगी. मेरी जो क्या कहना चाहिए एक्सटेंसर मसल्स है इरेक्टर स्पाइने, वो इतना टॉर्क जनरेट कर ही नहीं पाएंगी. एक तो रीजन इलेक्ट्रिकल साइलेंस हुआ. दूसरा रीजन ये हुआ कि क्योंकि जो मेरी अपर बॉडी का जो एक्सटेंसर लोड है वो और जो फल्क्रम था वो काफी क्लोज आ जाएंगे. इस पोजिशन में वो क्लोज आ जाएंगे, तो जो इंटरनल मोमेंटम है दैट हैज टू बी जनरेटेड बाय द इरेक्टर स्पाइने, that is the internal force or the internal torque, that will the external load will enhance or supersede that internal torque. Okay, so मेरी erector spinae वो torque generate नहीं कर पाएगी क्योंकि जो axis of rotation या insertion of erector spinae है that will come quite closer to that of the axis of rotation of the lumbar spine, right? तो in this case इसी वजह से मेरी erector spinae work नहीं कर पाएगी वहां पे. राइट, तो इस फेज में अब क्या होगा, तो इस फेज में देयर आर टू मसल्स दैट वर्क टू इनिशिएट कमिंग बैक फ्रॉम फॉरवर्ड बेंडिंग. ओके, नाउ हैमस्ट्रिंग एंड gluteus maximus will get activated and they'll pull the pelvis back. I'll tell it to you in the next. So my hamstring and gluteus maximus are working to pull my pelvis posteriorly. Now, once they are pulled back, the insertion or the attachment of the erector spinae will move away from the axis of rotation of the lumbar spine. Now, if this will move away, this will generate some amount of momentum here. Okay, this will generate some amount of momentum for erector spinae muscles. तो अगर इतना मोमेंटम एक बार जनरेट हो जाएगा तो जनरेट होते ही वो टॉर्क पिकअप कर लेगी, ठीक है ना। तो वो मसल जो है इरेक्टर स्पाइनी जो इस बार है, जनरेट हुआ थोड़ा सा टॉर्क और उससे जनरेट हुआ थोड़ा सा मोमेंटम और उसने टॉर्क को पिक कर लिया और टॉर्क को लेते ही, टॉर्क बढ़ाते ही सडनली इट स्टार्टेड टू पुल माय अपर बैक back from the forward bending back into the extension. All right, so this is something about the erector spinae, or that is something about the lumbopelvic rhythm I wanted you people to know about. Okay, coming on to the probably last part of the kinematics here, or the arthrokinematics, that is the frontal plane kinematics. Frontal plane में हमारा motion कौन सा होता है? That is the side bending, and we have almost 20 degrees of side bending available here. It is again the same thing that we have talked about in the cervical spine also and in the thoracic spine also. If I am bending on the right side, the inferior facet of the superior vertebra on the ipsilateral side would move posterior and inferior. The ipsilateral side का जो inferior facet of the superior vertebra है will move posterior and inferior. That on the left side will go anterior and superior. ओके अगर मैं राइट साइड में बेंड हो रहा हूं तो राइट साइड का जो इंफीरियर फेसेट ऑफ द सुपीरियर वर्टिब्रा है इट विल गो पोस्टीरियर एंड इंफीरियर. कॉन्ट्रालेटरल साइड यानी कि लेफ्ट साइड का जो वर्टिब्रा है इट विल गो एंटीरियर एंड सुपीरियर. Okay, so this motion will be limited by the tensile strength of the stretching in the intertransverse ligament also. Okay, it is by the tensile strength of the capsule, posterior capsule of the zygapophyseal joint on the contralateral side also, right? And usually rotation and side bending movements are not single movements. They are coupled motion. ठीक है ना? जब भी मैं side bending करता हूं तो it is usually associated with contralateral side rotation. Okay? या फिर अगर मैं rotation करता हूं किसी एक side में, it is also usually associated with contralateral side of my side bending. Okay? So this is known as the coupled motion, which is quite exclusively available in the lumbar spine and your cervical spine also. Probably less in the thoracic spine because there is less margin of movement over there. Okay, now coming on to the one of the most important parts of the lumbar spine biomechanics today. So always remember, अब जो मैं बात कहने जा रहा हूँ आपको बड़ा गौर से बड़ा ध्यान से सुनिएगा इस चीज को, ठीक है? अच्छा, ये जानने से पहले मैं एक छोटी सी चीज आप लोगों को पहले बता देना चाहता हूँ कि जब भी हम कोई फोर्सेस रिजॉल्व करते हैं, मान लीजिए दिस इज अ पॉइंट और इस पॉइंट से यहाँ फोर्स लगा है. अब इस फोर्स के मैंने दो कंपोनेंट्स रिजॉल्व किए. वन इज द वर्टिकल कंपोनेंट, द अदर वन इज द हॉरिजॉन्टल कंपोनेंट, राइट? सो व्हेनेवर आई टॉक अबाउट द वर्टिकल एंड द हॉरिजॉन्टल कंपोनेंट, ऑलवेज रिमेंबर दैट द हॉरिजॉन्टल कंपोनेंट इज द कंपोनेंट ऑफ sin theta. Okay, the horizontal component is the component of sin theta and this is the component of the cos theta. Okay, vertical one, ठीक है ना? So always remember this. Now coming back to its own position, its our own slide. अब क्या हुआ? अब ये हुआ कि जब जो हमारा सैक्रम है, सैक्रम का जो बेस है, या फिर मैं ऐसा कहूं कि S1 का जो बेस है, S1 की जो वर्टिब्रल बॉडी अलाइनमेंट है, इट इज नॉट हॉरिजॉन्टल, it is aligned at some angle. Okay, it is inclined, it is available inclined like this. Okay, now this inclination is at certain angle. Now this angle, if I make this angle with the horizontal, it comes out to be nearly 40 degrees. This angle is known as sacro-horizontal angle. This is the physiological inclination of the base of sacrum from the normal or the horizontal is known as sacro-horizontal angle. The normal value of sacro-horizontal angle is 40 degrees. Now, in case if lordosis increase and if anterior pelvic tilt increase, which will increase the nutation of the sacrum, the nutation of sacrum in turn will increase. अच्छा, अगर nutation होगा तो ये और नीचे आ जाएगा, और नीचे आ जाएगा तो ये angulation बढ़ जाएगा. Now what happens when the sacro-horizontal angle increases? Okay, you can see that a sacro-horizontal angle of 40 degrees produce a shear force equalizing about 64% of the body weight. That is more than half of the body weight का जो shear force होता है वो सिर्फ L5 और S1 के बीच में exist करेगा. Okay. Now in case of the lordosis increases, making the sacro-horizontal angle to 55 degree, that is 15 degree increase in the sacro-horizontal angle, the shear force would increase up to 82% of the body weight. राइट मान लो अगर मेरा 100 kg वेट है तो ऑलमोस्ट 80 kg वेट के बराबर का फोर्स जो है इट विल बी एम्प्लॉयड बिटवीन योर L5 एंड S1 अगर मेरा सेकंड हॉरिजॉन्टल एंगल 40 डिग्री से बढ़कर के 55 डिग्री हो जाता है तो राइट. नाउ आई विल कम ऑन टू द सेकंड पॉइंट. In standing position, the body weight produces an anterior shear force. क्योंकि थोड़ा सा पीछे से निकल रही है line of axis, तो हमेशा this angulation will allow or will cause the base of the sacrum to move forward. Okay. Now this moving forward will have some amount of forces that will be acting between the two articular surfaces of the L5 and S1. तो अब वो force जो कि इस movement को रोक रहा है, that will be the shear force. Okay. The body weight produces an anterior shear force and a compressive force. Okay. Now this vertical alignment is the compressive force which is coming directly down, or compressive force could be more onto the facet joint. Okay. और इसीलिए compressive force के opposition में एक force जाएगा, that will be the joint reaction force. But the joint reaction force doesn't go like this. It goes opposite to the shear force in this direction, right? So it goes like this. Now. And compressive force, that is BWN, acting perpendicular to the base of sacrum. Okay. Now what happens is whenever there is a force which is acting into this direction, मैं आपको next slide पे ले जाता हूँ. अब एक force है जो shear force है वो इस direction में act कर रहा है, right? There is this force which is acting like this. Now there is only one force, or there is a one force, that is the muscular force, which is acting to counterbalance this force such that we can reduce the sacro-horizontal angle and we can counterbalance the shear force which is acting between L5 and S1. Now if I consider iliocostalis muscle or the erector spinae muscle that is working between L5 and S1, it has little more angulation. अगर मैं बात कर रहा हूँ यहाँ की तो इसका angulation ज्यादा है. Okay. Let me just do it. एक मिनट यहाँ. So अगर मैं इस angulation की बात कर रहा हूँ, अगर आप देख पा रहे हैं तो this angulation is more in comparison to the angulation if you can see it here. Okay, ये angulation जो है वो L5 S1 की erector spinae का है because they are more obliquely aligned, because they have their attachments quite near to that of the iliac crest. तो उनका angulation हमेशा से ज्यादा ही होगा. All right, you can see it here also. Here, right? So it is quite straighter, right? यहाँ पे बिल्कुल straight है, लेकिन यहाँ पे बहुत ज़्यादा angulated है. Now this angulated structure or this angulated force is counterbalancing the force, the shear force which is being employed between L5 and S1 because of the body weight which is falling. Now just take this little amount of advice that if this angulation reduces, okay, if I draw an angle from the normal, okay, now if this angulation eventually decreases, or when lordosis increases, this angulation would rather increase. So अगर ये increase होगा, so there will be more force in this direction, which will be acting in this direction, right? So this muscle will have to allow for more force. Okay, now if this angulation will increase, this point will get closer to the point of attachment onto the iliac crest also. Now if it will get closer, the momentum will eventually reduce. Okay, if the momentum will reduce, the torque will also reduce. Now in that case, to match up with this force, the muscle will have to work more, will have to generate more force. Okay, now if in case I'm just giving you a very important clinical insight now. अब हमको क्या करना है, हमारे पास दो फोर्स है, एक तो है shear force, ठीक है ना, उसको काउंटरैक्ट करता हुआ है इरेक्टर स्पाइने का फोर्स. ओके, अब क्योंकि लॉर्डोसिस बढ़ रहा है तो इवेंचुअली मोमेंटम कम हो रहा है और इसका जो टॉर्क था वो कम हो रहा है. अब इसके टॉर्क को बराबर रखने के लिए इस फोर्स को बढ़ना पड़ेगा. अगर इस फोर्स को बढ़ना पड़ेगा तो ये मसल जल्दी थक जाएगी, फटीग हो जाएगी. दिस मसल वुड रादर गो इनटू प्रोटेक्टिव स्पैज्म and it will cause pain and other mechanical low back pain sort of thing. Agar if this muscle fails to do this, this will eventually overcome this force. If this increases this force, then sacrohorizontal will increase and this will start moving forward, causing spondylolisthesis. So there is quite important what you can say amalgamation of these forces working into the opposite direction. Now what we can do is, it's just a hypothetical point of mine, it's totally up to you if you take it or not. Now if the distal attachment lies onto the posterior lip of the iliac crest, if in my manual therapy, if in my treatment I start pulling the posterior lip of the iliac crest back, if I perform a posterior glide to it, sustain a posterior glide, then I ask the patient to perform movement of the hip joint, movement of the lumbar spine. In that case, I can counterbalance, or I can rather increase this torque generated by the erector spinae, because by this I am altering the momentum, because I am changing the point of attachment on the iliac crest. Change nahi kar raha hu, I am taking it away. If I am taking it away, eventually the momentum will increase. If the momentum will increase, the torque generated by the erector spinae will also increase. If the torque generated will increase, it will easily counterbalance the shear force. Either I can do this, or I can sustain the glide, put up a tape there and just sustain that particular position, and then I ask the patient to perform that particular movement. So I don't know how much it will work or not, but this can be a very important clinical insight. And if I'm not wrong, it is a part of your Mulligan technique also. Okay, it is one of the very important glide treatment glide in the Mulligan type of mobilizations also. All right. So always remember that we can do this particular thing. Okay, this was just a clinical insight. In fact, if we try to do some amount of researches which can give us the forces generated by the erector spinae or the shear forces acting between L5 S1, we can definitely perform this study, this randomized controlled trial. Okay, so we can do that. So although it's a separate thing that we are talking about. So moving ahead, coming on to the muscle interaction. So we have a set of anterior group of muscles, that is the abdominal muscle. We have a posterior group of muscles, that is the extensor muscles, right? The extensor muscles include your erector spinae majorly, followed by your what you can say, Quadratus lumborum. You have small muscles like multifidus, rotators. You have a semi-spineless muscle. You have n number of muscles. Latissimus dorsi you have, so you have a lot of muscles. Talking about the anterior compartment of the muscles, you have abdominal muscles like rectus abdominis. You have transverse abdominis. You have oblique muscles. So you have a lot of muscles which are coming here also. Iliopsoas muscle is also there, or iliacus, psoas major muscle is also there, right? Which is also an anterior compartment muscle. So bilateral action of these muscles reduces the distance between xiphoid process and pubic symphysis. That is the flexion of the lumbar spine, right? Now the axis of rotation for all motions are biased posteriorly in trunk through the vertebral bodies. Rectus abdominis has most favorable leverage, although it has most favorable momentum also, and it is one of the muscles which has one of the largest cross-sectional area, including the extensor and abdominal flexor muscles. Extensor flexor muscles अगर सब भी मिला लें तो उनमें से भी क्रॉस सेक्शनल एरिया जो रेक्टस एब्डोमिनस के पास है उतना जो एरिया है क्रॉस सेक्शनल एरिया वो किसी मसल के पास नहीं है. ओके, all muscles except for psoas major has leverage in both sagittal and frontal planes. psoas major के पास क्यों नहीं है वो हम अभी बात करेंगे थोड़ी देर में. Acting unilaterally, the abdominals can efficiently be the lateral flexors, okay, and rotators also. This action is attributed to the internal and external obliques owing to the larger momentum and favorable cross-sectional area. Their cross-sectional area at L4, L5 is nearly double that of the rectus abdominis. अच्छा, ये ऐसा नहीं है कि एक ऑब्लिक का, इंटरनल और एक्सटर्नल ऑब्लिक दोनों मसल्स को मिला लोगे तब जो क्रॉस-सेक्शनल एरिया बनता है that is quite large and it is double to that of the rectus abdominis. Okay. सिंगली अगर देखोगे इंडिविजुअल मसल्स में हमेशा रेक्टस एब्डोमिनस का क्रॉस सेक्शनल एरिया सबसे ज्यादा होता है. So these are the locations of the muscles. So this is the external oblique muscle which is running like this. Okay, similarly, the internal oblique muscles runs like this. Okay, so they cross each other at perpendicular at 90 degrees. Okay, so the external oblique muscles are the more superficial muscles to the internal oblique, and the external oblique courses as if inserting hands into the pockets like this. So they are moving like this, and the internal obliques are moving like this. So they are moving like this, external obliques, and the internal obliques are moving like this. Okay, so they cross each other at 90 degrees. Okay, so the mean fiber direction of internal and external oblique muscles crosses perpendicularly to each other. Okay, transverse abdominis being the deepest of all, and it is one of the most important stabilizer of the lumbar spine. Not only lumbar spine, it is the abdominal corset. Okay, so it is the basic and the most important core muscle. Core muscles की हम बात कर रहे हैं ना कि core strengthening करते हैं, तो this is the core that we always talk about. Okay. Its primary function is to involve increasing intra-abdominal pressure and in stabilizing the lumbar region through attachments to the thoracolumbar fascia. Okay, so this is the transverse abdominis. It is running like this as a course or the corset. Okay, that is, it is the important core muscle, and the fiber direction of the internal oblique is like this. Okay, this. All right. So always remember this. Now, group action of the abdominal muscles. How do they work conjointly? Bilateral action of the abdominal decreases the difference. That is, the flexion is what they do. All the abdominal muscles are notably the rectus abdominis have very favorable momentum, except for psoas major muscles. All are potentiated to produce movement in both lateral frontal planes. Contracting, अच्छा important इसमें जो है वो ये है at L4 L5 the combined cross sectional area of internal external muscles is double that of the rectus abdominis. I think ये slide repeat हो गई वापस आपकी. Okay, so this is the same that we have talked about. Okay, this is the same thing. Okay, ये important है. The internal and external oblique muscles are potential axial rotators of the spine, as well as with the large combined cross sectional area and leverage also. Leverage, that is momentum. All right. During axial rotation, external oblique muscles work synergistically with the contralateral internal oblique muscles. All right, and the torque demands are relatively large during the high power axial rotation, like sprinting. Sprinting क्या होता है? I'm changing directions, so I have trunk rotation movements also, right? Or wrestling, or throwing anything, or javelin throws also, right? You have to turn, you have to rotate your lumbar spine. Okay, so you need thrust-like motion, thrust-like activities, and high-power activities are involved in such activities. Okay. Talking about the trunk flexor versus trunk extensor peak internal torque. Although we have larger cross-sectional area muscles in the abdominal muscles, but we have lot of muscles in the extensor compartment. More muscles are present in the extensor compartment. Okay. So the net magnitude of trunk extensors exceeds that of the flexors. Okay. फ्लेक्सर्स में मसल्स बड़ी हैं, क्रॉस सेक्शन एरिया ज्यादा है, लेकिन नंबर कम है. ट्रंक एक्सटेंसर्स में क्रॉस सेक्शनल एरिया कम है, लेकिन नंबर में बहुत ज्यादा है. वो खूब सारी मसल्स हैं, ठीक है ना. 9 तो इरेक्टर स्पाइन ही हो जाती है. ओके, उसके बाद दूसरी मसल्स आती हैं. So the ratio of peak torques determined isometrically for flexor to extensor is generally between 0.51 and 0.77. It is not even 1. Okay, इसका मतलब बराबर भी नहीं है. Okay, so it is always the extensor that exceeds the net torque. Okay, although the trunk flexors possess a greater momentum, but extensors possess greater mass and vertical orientation. अच्छा, इसमें जो है orientation सबका अलग अलग है. If you can see it here, इसका orientation ऐसे है, ऐसे है, इसका orientation ऐसे है. अगर मैं और पीछे जाऊंगा तो इसका orientation straight है, इसका orientation ऐसे है, right? So every muscle has a different orientation. But whenever we talk about the extensor group of muscles, so they have vertical orientation also only. Okay, उनका सब ऐसे ऐसे चलता रहेगा. ऐसे होगा, लेकिन they'll be vertically downwards. Okay, so the action will stay same. Coming on to the additional muscles of the iliopsoas. Iliopsoas is a very important muscle. It arises from the transverse processes of the T12 or L1 and L2, L3, L4, and also from L5, and further it blends with iliacus and gets attached to the lesser trochanter, making it a very potential flexor for the hip joint. But it is quite close to that. If you can see that if my axis of rotation is this, it is taking an attachment with here. So the momentum for this is T12 is very less. Similarly, the momentum for L1 also is less. L2 is also less. But as I see it goes deeper, it goes down distal, eventually the momentum increases, as although it doesn't increases too much, but it increases in comparison to that of the T12, L1, L2. So it is a very good stabilizer of the upper lumbar spine, but it is a good mobilizer for the lower lumbar spine, right? So always remember that psoas major has a favorable momentum for lateral flexion because it has some amount of momentum in the frontal plane, and lesser one for axial rotation. It possesses 2 centimeter momentum in the sagittal plane for the lower lumbar spine. Till L1, the line of force shifts posteriorly, reducing the momentum, because the line of force, the line of gravity runs somewhere from here. So eventually it reduces the momentum for every segment, right? So it is not a good flexor or extensor, but a good vertical stabilizer of the lumbar spine, right? It is not a good mobilizer or stabilizer, but it is a very good vertical stabilizer of the lumbar spine. Always remember that, right? Coming on to the additional muscles, now this is the posterior compartment muscle, that is the quadratus lumborum muscle. Now contracting bilaterally, it is a potential extensor, although you can see that it is quite far away. So it has good momentum in the frontal plane. Okay, so it can be very potential side flexor. But whenever both the sides bilateral, the quadratus lumborum is acting, it acts as a very good extensor also. Its line of action passes 3.5 centimeter posterior to the medial lateral axis of rotation at L3. So it has sufficient amount of momentum in the sagittal plane also. Now acting unilaterally, it has essential leverage to produce lateral flexion of the lumbar spine. It is also known as the hip hiker muscle, because if your contralateral side gluteus medius is not working, this muscle can contract and lift the pelvis superiorly. Okay, so this can also act in cases of your hip hiking. Okay, so it is also known as the hip hiker muscle, especially in those with paraplegia below L1. Okay, because in L1 this is being spared, so this can act for your gluteus medius. Now coming on to the one of my favorite group of muscles, that is the erector spinae. You all people know about erector spinae. We just have to notify the names of the 9 erector spinae, right? 9 erector spinae के नाम हम जानते हैं. वापस से मैं सिखाऊंगा आपको. Last class में भी we had talk about it. So we have 4 components जहाँ से पास होती है. One is the head. Head की muscles को हम हमेशा कहते हैं capitis. Okay. Neck की muscles को we always call it as cervicis. Thorax की muscle को we call it as thoracis. And lumbar की muscles को we call it as lumborum. Okay. Now this is the first component, second component, third component, and fourth component. We have the major muscles available in the erector spinae are spinalis. Okay. Second is longissimus. Okay, and third one is iliocostalis. Okay, now spinalis has 1, 2, 3. All the 3 muscles has 3 fibers. Okay, longissimus has 1, 2, 3, and also iliocostalis has 1, 2, and 3. So spinalis at number 1 is spinalis capitis. Okay, spinalis has at number 2 is spinalis cervicis. Spinalis at number 3 is spinalis thoracis. Okay, longissimus at number 1 is longissimus capitis. Longissimus at number 2 is longissimus cervicis. Longissimus at number 3 is longissimus thoracis. Iliocostalis doesn't have number 1. Iliocostalis has 2, 3, and 4. Okay, so iliocostalis at number 2 is iliocostalis cervicis. Iliocostalis at number 3 is iliocostalis thoracis. Iliocostalis at number 4 is iliocostalis lumborum. Okay, so these are the 9 erector spinae muscles. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, so these are the 9 muscles that you people must remember whenever you are being asked about your erector spinae. Okay, now I'll be telling one important thing. Spinalis, as the name suggests, it lies quite close to the center of the spine. Okay, so it can generate a sufficient momentum in the sagittal plane for extension, but it does not have a sufficient momentum in cases of your side bending or rotation. Okay, on the contrary, if I talk about the longissimus, longissimus is a muscle which is quite away from the axis of rotation. Okay, in the frontal plane also and in the sagittal plane also. So it has significant torque generation for extension also and side bending, lateral flexion also. When I talk about the iliocostalis, iliocostalis lies somewhere between longissimus and spinalis muscle. So it again has a substantial or a satisfactory amount of momentum in a sagittal plane also and in a frontal plane also, right? So it is also a very potential extensor also and a lateral flexor of the lumbar spine also. Okay, I hope that must be clear for you people. Now this is the deepest group of muscles we have already talked about. That is the transversospinalis group of muscle. It contains muscles like semispinalis thoracis. It contains the muscles like multifidus. It contains the muscles like rotator longus and brevis. Rotator brevis, as you can see, that it is the most deepest one. If it is the most deepest one, it has the lowest momentum. If it is the lowest momentum, so it is the eternal stabilizer of this particular muscle, of this particular segment, right? Although transversospinalis muscles have been given this name because they start from one transverse process and gets attached onto the spinous process of one or two segments above, okay, or the alternate segments above. All right, these muscles helps in segmental rotation, and obviously, yes, they also helps in segmental stabilization also because they have lesser momentum. Okay, lesser momentum in the sagittal plane, although they have good momentum in your rotational things, horizontal motion. Now coming on to another very important part of our topic today, that is the analysis of forces in lifting heavy weight. Now suppose there is a man of say 80-81 kgs, or you can say that 800 newtons, who is lifting a weight and have held that weight in semi squat position. Okay, एक आदमी है जिसने वजन जमीन से उठाया और उसने सेमी स्क्वाट पोजीशन में इसको होल्ड कर लिया, ठीक है ना. नाउ वी हैव सम डेटा व्हिच इज बीइंग गिवन हियर. इस आदमी का जो टोटल वेट था दैट वाज 180 पाउंड्स एंड इवेंचुअली उसका जो फोर्स निकल के आता है दैट इज ऑलमोस्ट 800 न्यूटन्स. ओके, नाउ द पार्शियल बॉडी वेट यानी कि HAT का जो कि L2 पे पड़ रहा है, वी हैव टेकन द एक्सिस ऑफ रोटेशन और द फुलक्रम ऑफ रोटेशन टू बी L2. ऑलराइट, सो L2 से ऊपर का जो बॉडी वेट है दैट वी हैव टेकन 65% ऑफ द टोटल बॉडी वेट. नाउ 65% ऑफ 800 न्यूटन कम्स आउट टू बी 520 newtons. Okay, now we have some other values also which are being given by the help of cadaveric studies and other biomechanical analysis. Now if I talk about the erector spinae muscle, so the momentum for the erector spinae muscle at the level of L2 is called as D1, and the value of D1 here is 5 centimeter. Okay, so the internal momentum what we have today here is 5 centimeters. Okay, now we have two external loads here. First external load is because of the body weight which is falling from here. If you can see it here, this arrow is showing you the body weight. So the body weight is falling from here, and we have another weight which has been lifted in the hands, okay, in the arms. So the weight of the external load is falling from here. So we have a distinctive momentum for the external load also and for the body weight also. So the body weight, so the momentum for the body weight, MABW also I can call it, but they have called it in a very easier manner, that is D2. So D2 comes out to be 13 centimeter to us, and that of the external load which is held in the arms is D3, which is 29 centimeters. Now they have given that the external load is almost 25% that of the body weight, that is 1/4 of the body weight. Okay, 1/4 of the body weight, which was 800 newtons, that becomes now 200 newtons. Okay, so we have a lot of values here. Now if the person static in this position is held in this position, so I'll always say that internal torque will be equal to the external torque, right? Everybody must be agreeing with me. External torque, Okay, now internal torque is because of the erector spinae, but we don't know what is the force of the erector spinae, right? So I'll write it, force erector spinae, it will be multiplied by the internal momentum, that was my d1, so I'll keep it d1 here. Now we have two external momentums, so I'll take one with the body weight first. Okay, so force body weight multiplied by your d2, that was the momentum because of the body weight, plus the force external load multiplied by d3, that is the momentum because of the external load. Now I don't have this value. Okay, now force external erector spinae multiplied by 5 centimeters, that will be followed by force body weight. Now body weight was 520 newtons multiplied by d2, d2 की वैल्यू क्या थी हमारे पास 13 सेंटीमीटर, राइट, प्लस एक्सटर्नल लोड वाज 200 न्यूटन्स मल्टीप्लाइड बाय 29. अच्छा, अगर मैं इसको सॉल्व कर लूं तो इरेक्टर स्पाइनी का जो फोर्स है मेरे पास वो क्या आएगा, लेट मी सॉल्व इट. ओके, सबसे पहले मैं मल्टीप्लाई करूंगा 520 न्यूटन्स को 13 से, तो इट विल कम आउट टू बी 6760 प्लस 29 को मैं मल्टीप्लाई करूंगा 200 से, यार मेरी मैथ्स इतनी अच्छी नहीं है, सो प्लीज बेयर विद इट, प्लस 5800 एंड इट विल बी डिवाइडेड बाय 5, सो व्हाट विल कम इज प्लस 6760, ओके, डिवाइडेड बाय 5. So the value which is coming here is 2512 Newton. Okay. Now the value which is coming here is 2512 Newton. अगर आपको मैं थोड़ा सा ऊपर ले जाऊं, हमारा बॉडी वेट कितना था 800 न्यूटन. अब जो मेरे एक सेगमेंट मैंने वेट कितना उठाया 1/4 ऑफ द बॉडी वेट, तो अगर मैं 1/4 ऑफ द बॉडी वेट को लिफ्ट कर रहा हूं तो what I require is I require my muscle, my erector spinae to work 3 times. तो जो वो फोर्स लगा रही है that is nearly 3 times that of my body weight. मैं वेट कितना उठा रहा हूं 1/4 ऑफ माय बॉडी वेट, लेकिन मेरी इरेक्टर स्पाइने कितना काम कर रही है 3 times that of the body weight. It is working so as to lift that weight, keep that weight lifted in my arms. Okay, तो वो 3 गुना ज्यादा काम करना पड़ रहा है उसको. अब क्या हुआ कि ये फोर्स भी काम लग गया, ये फोर्स भी कैसे चल रहा है, नीचे चल रहा है, बॉडी वेट का फोर्स भी कैसे चल रहा था, नीचे चल रहा था, एक्सटर्नल लोड का फोर्स भी कैसे चल रहा है, नीचे चल रहा है. तो सारे फोर्सेस नीचे चल रहे हैं, तो जो ज्वाइंट रिएक्शन फोर्स होगा वो तो ऊपर चलेगा, ऑपोजिट टू इट. ठीक है ना. तो अब अगर मैं कैलकुलेट करने की कोशिश करूं ज्वाइंट रिएक्शन फोर्स, तो ज्वाइंट रिएक्शन फोर्स विल बी माइनस, बिकॉज हमने कहा है स्टैटिक पोजीशन में है, इंटरनल एक्सटर्नल टॉर्क इज इक्वल, सो द रिजल्टेंट फोर्स व्हिच इज एक्टिंग ऑन टू L2 L3 सेगमेंट मस्ट बी 0. सो JRF माइनस फोर्स बाय इरेक्टर स्पाइने माइनस फोर्स बाय बॉडी वेट माइनस फोर्स बाय एक्सटर्नल लोड मस्ट बी 0. नाउ लेट मी पुट ऑल द वैल्यूज. JRF इक्वल टू 2512 प्लस बाकी कहाँ गया 520 प्लस 200. ओके, कैलकुलेट करना पड़ेगा भाई, मेरी मैथ्स इतनी अच्छी नहीं है, सो आई विल बी रिक्वायरिंग कैलकुलेटर. ओके, 2512 प्लस 520 प्लस 200, सो इट इक्वलाइजेस 3232 न्यूटन. ओके, सो अगर वापस से आ जाता हूं मैं इस चीज पे, अगर मैं एक ऐसा वेट उठा रहा हूं जो कि 1/4 ऑफ माय बॉडी वेट है, तो एक पर्टिकुलर जॉइंट सेगमेंट पे जो फोर्स चल रहा है दैट इज 4 टाइम्स ऑफ माय बॉडी वेट. मेरा बॉडी वेट तो 800 न्यूटन ही था ना. सो एक सेगमेंट के बीच में जो वेट चल रहा है, जो फोर्स आ रहा है कंप्रेसिव फोर्स, दैट इज 4 टाइम्स दैट ऑफ माय बॉडी वेट. फिर हम कहते हैं कि भाई हमारी डिस्क क्यों खराब हो रही है, हमारी डिस्क इसलिए खराब हो रही है. ओके, this is the reason why I require various strategies to be employed which could reduce this loading. अब मैं क्या करूं, मैं क्या ऑल्टरेबल क्या है, मैं क्या इसका मोमेंटम इरेक्टर स्पाइने का चेंज कर सकता हूं, मैं नहीं कर सकता. क्या मैं D2 को चेंज कर सकता हूं? हाँ, मैं D2 को कैसे चेंज कर सकता हूं, अगर मैं अपनी बॉडी को स्ट्रेट रखूंगा. ठीक है ना. अगर मैं जितना ज्यादा झुकूंगा मेरा जो लाइन ऑफ ग्रेविटी है वो उतनी बार निकलती जाएगी और D2 की वैल्यू उतनी ज्यादा बढ़ जाएगी. तो अगर मैं खुद को सीधा रखूंगा तो D2 की वैल्यू कम हो जाएगी, D2 की वैल्यू कम होते ही ये वैल्यू कम हो जाएगी. ओके, ये वैल्यू कम होते ही ये वैल्यू कम हो जाएगी और इनफैक्ट ये वैल्यू भी कम हो जाएगी. अच्छा, क्या मैं D3 को ऑल्टर कर सकता हूं? हाँ, मैं D3 को भी ऑल्टर कर सकता हूं. इसीलिए हम कहते हैं कि जिस भी वेट को आप लिफ्ट कर रहे हो कीप इट वेरी क्लोज टू योर बॉडी, ठीक है ना। अगर बॉडी से क्लोज रखोगे तो ये कम हो जाएगा, या फिर कीप इट बिटवीन योर लेग्स, तो अगर ये कम हो जाएगा तो ये वैल्यू कम हो जाएगी, और इनफैक्ट ये वैल्यू भी कम हो जाएगी, राइट। तो ये वैल्यू कम होते ही ये वैल्यू यहां से कम होगी, और इनफैक्ट ये वैल्यू भी जो JRF की है वो भी कम हो जाएगी, right? So if I have to reduce compressive loading at my single segment, in that case I always have to keep my back straight. I have to keep the load which I'm lifting close to my body, or rather keep it between the legs, right? So अगर सोचो ये एक सेगमेंट पे ये है, अगर मैं पांचों सेगमेंट का कैलकुलेट करने बैठूंगा तो इट विल कम अराउंड आई डोंट नो हाउ मच, 15,000 के ऊपर आ जाएगा, ठीक है ना। 5 सेगमेंट के लिए दिस लोड विल बी 15,000, मोर देन 15,000 न्यूटन्स, सो दिस बिकम्स टू मच, ठीक है ना। दिस इज द रीजन व्हाई दिस सेगमेंट, द लंबर सेगमेंट, इज मेंट फॉर मोर स्टेबिलिटी, more meant for load absorption, okay. It is exposed to loads like shear, bending, compression, torsion, every sort of load it is experiences or being exposed to, right. I think this must be clear to you. This was a very important fact that I wanted to share it with you people. This is the total thing that I was talking about, okay. Coming on to the last segment of my talk today, that is the sacro-iliac joint. Sacro-iliac joint is a wonderful joint which acts as a key link between your upper body and your lower body. This segment is very important. Sacrum is very important to shift load from your upper body to the lower limb, because it is the only way from where you can just transfer load of the upper body into the. So I won't talk too much about it, क्योंकि इसका जो S1 segment होता है, it is 5 vertebras which are blend with each other, ठीक है ना, fused vertebras होते हैं. You have very straight, flat superior articulating facet of the S1 joint. S1 I mean, which articulates with the inferior articulating surface of the L5 segment. Okay, talking about the major ligaments of the SI joint, so we have anterior sacroiliac ligament. So if you can see here, these are the anterior sacroiliac ligaments. They form the anterior margin of the capsule of the SI joint, and they are quite thickened. And the fibers of the anterior sacroiliac joint ligament, eventually they blend with the capsule of the sacroiliac ligament also. Okay, so they help us to get the anterior stability. Next to it, deep to it, lies your interosseous ligament. Interosseous ligament is again a very thick band of ligament, and again it blends with the capsule of the sacroiliac ligament, such that you are not able to recognize which one is the capsule and which one is the interosseous ligament. And it is again very helpful to give anterior stability to the sacroiliac joint here. Okay, coming on to the other ligament, that is the short and long posterior sacroiliac ligament. I'll show it to you here. Okay, now these are the short superior ligaments. Okay, posterior ligaments. We have long posterior ligaments also. So it starts from the spinous process, or from the S2 segment, S3 segment, S4 segment. They run towards the PSIs, the short ones, and the long ones just below to the PSIs towards the rami. Okay, they try to get their attachments onto it. Okay, so they are helpful in getting the posterior stability of the SI joint. Okay. Now there are few secondary ligaments, because these are those ligaments which do not have direct attachment onto the sacrum, but they influence the sacroiliac joint. Okay, the first in this part is sacrotuberous ligament. Sacrotuberous ligament is the strongest ligament of the body, right? So this is the sacrotuberous ligament. Its name is such because it takes its origin from the internal lateral angle of the sacrum, that is ila of the sacrum, and it attaches onto the ischial tuberosity right here, right? It has two bands, one which is coming from here, from the other parts of the sacrum, and one from the PSIS as well. Okay, so it has 2-3 fibers which are coming. So it does not have any direct attachment to the sacroiliac joint, but it crosses it, and it controls its tensile strength, controls the excessive nutation which is coming into the sacrum. अगर sacrum ज़्यादा nutation में जा रहा है, anterior tilting में जा रहा है, तो पीछे से जो ये pull है, जो कि tensile strength से आ रहा है sacrotuberous ligament की, वो control करता है इस particular joint, right? Sacrospinous ligament is another ligament. वो भी मैं आपको यहीं से दिखा सकता हूँ. It attaches onto the spine. It starts from the ila of the sacrum anteriorly and it attaches onto the spine of the pubis here, right? The other one is the iliolumbar ligament. It starts from the transverse process of L4, L5. This is the L4 and this is the L5 transverse process, and the ligament which is running here is iliolumbar ligament here. Okay, so it defines the frontal plane stability of the L4, L5 also and L5S1 also. Okay. Now talking about the other things, that is the kinematics of the sacroiliac joint. The kinematics of the sacroiliac joint includes two motions, right? Although there are a lot of torsions which are available in this particular segment, but it is not isolatedly available, right? The major movements that are available here are nutation and counter nutation. Whenever the base of sacrum moves anteriorly with respect to the other pelvic cage, it is called nutation. Whenever the base of the sacrum moves posteriorly with respect to the the pelvic cage, it is called counter nutation, right? So the total motion that occurs in the range of 0.2 to 2 degree and an active translation of 1 to 2 millimeter is observed in the sacrum, right? The passive excursion is about 7 to 8 degree during extremes of bilateral hip motion is being observed here, right? Talking about the last segment of the day is stress relief. Now, movement at the sacroiliac joint provides stress relief whenever I am walking because of the torsions available in the sacrum while I'm walking. It gives us some amount of relief and efficient weight transference, right? In advancing limb, when the heel strikes the ground, the tension in the hip muscles and the ligaments generate oppositely directed force on the right and left iliac crest, and it tries to torsion in the opposite direction, right? It faces on the opposite direction. So it's a different class and a different topic to be discussed all over, right? Increased nutation is always there during the childbirth also, which increases the volume or the increase or the diameter of the pelvic outlet, okay, which eases the passage of the infant or the child from there, right? So it has actions like stress relief also. The other actions include the stability during the load transfer. One of the very important thing that you need to learn is whenever I am into standing position, the line of gravity always falls anterior to that to the base of sacrum. Now, if it will fall anterior to the base of sacrum, the physiological torque that is available for sacrum is the nutation torque. Similarly, when I'm standing and when I'm talking about the line of force of the joint reaction force of the hip joint, this also passes anterior to that of the sacrum. This eventually causes the pelvis to rotate posteriorly, but because of its alignment anterior to that of the base of sacrum, it has a physiologically generating nutation torque at the sacrum, right? So both these forces are compelling the sacrum to go into nutation. Now, this excessive nutation is being controlled by the contractile tissues also and non-contractile tissues also. The contractile tissues I already told you about the sacrospinous ligament, sacrotuberous ligament, and the other structures also. Talking about the contractile elements of it, so we have muscles also which crosses the hip and trunk that stabilizes the SI joints. So these muscles has a few actions that includes generating active compression force against the articular surfaces. Now, I'll tell you one thing that I have talked about a lot of times previously also, that the muscles which are in close conjugation with the joint, they have lesser momentum. Eventually, they will be working as better stabilizers. The muscles which are lying away from the say joint surface, which are more superficial, they have larger momentum and they'll be acting as mobilizers. Although we don't have too much of the movement available at the SI joint, but we need more stabilizers, more contractile stabilizer muscles over here, right? So increasing magnitude of nutation, torque, and locking the sacrum, pulling the connective tissue that reinforces the joint. So we have all these action of these muscles which are lying here. So the muscles involved here includes erector spinae, especially the iliocostalis muscle, the lumbar multifidus muscle, the abdominal obliques, rectus abdominis, transverse abdominis muscle, because they also form very important part of the core muscles, right? We have hamstring also, which has a constant posterior pull to the pelvic muscle, right? So I hope that must be clear to all of you people. Thank you so much for being here. If you have any more questions coming here, so you can definitely ask me. Okay, I'm all open for questions now. If you have any questions, you can please ask me the questions. Although we don't have too much people left today, if you have any questions, you can please ask me. If you people have any questions, you can please ask me. Do you have any questions? You can write it in the comment box. I'll be much happy to answer them. Okay. If you have any questions, you can please write it in the comment box. If you have any questions, I cannot see any questions till now. If you have any questions, please, you can write it down. Okay, if you don't have any questions, thank you so much, everybody, for being here. And we are very soon launching with the other parts of the RPSC paper solving that you'll be seeing today. By today, I'll be launching it, releasing it. So, and in the next week, we'll be meeting with our final module. Okay, we have a question here. So, how does pubic symphysis play a role in stress relief? Definitely, it is a cartilaginous joint. Whenever you have increased diameter of the pelvic cage, the articulating surfaces separates with each other, right? They do not disarticulate. Okay, please describe about phase of electrical silence. Okay, so whenever I bend down completely, जब मैं पूरा ही नीचे झुक जाता हूँ, तो जब मैं पूरा नीचे झुक जाता हूँ, तो वो एक स्टेज होती है जब जहाँ पे मेरी इरेक्टर स्पाइनी जो मसल्स होती हैं, they do not work, they are electrically silent. ठीक है ना, वहां पे उनका एक्शन बिल्कुल भी नहीं होता है, तो उनका एक्शन बिल्कुल भी नहीं होता है, तो उसको हम फेज ऑफ इलेक्ट्रिकल साइलेंस कहते हैं. और जो भी अपर बॉडी का लोड होता है, जो कि नीचे फॉल कर रहा होता है, उसको मेंटेन करने की जो जिम्मेदारी होती है, वो वहां पे नॉन कॉन्ट्रैक्टाइल टिश्यूज जितने भी होते हैं उनके ऊपर आ जाती है. राइट, प्लीज एक्सप्लेन अबाउट द फॉर्म क्लोजर एंड फोर्स क्लोजर. ओके, ऑल्दो इट इज अ वेरी डिफरेंट टाइप ऑफ कांसेप्ट. चलो ठीक है, मैं बता देता हूँ. देखो, फॉर्म क्लोजर का मतलब होता है, हम दो कंपोनेंट की बात करते हैं व्हेनेवर वी टॉक अबाउट द एसआई जॉइंट स्टेबिलिटी. सो व्हेनेवर इफ यू सी स्ट्रक्चर ऑफ sacrum, it's not a straight bone, although it's a flat bone like scapula, but it's not a straight bone, right? It is quite curved from the superior surface like this. Okay, so it is the surface of the sacrum positions like this somewhere, right? तो हुआ क्या कि जब भी हम ऐसे रखते हैं, तो यहाँ पे जो दो फेसेट्स होते हैं जो कि आर्टिकुलेट करते हैं आपकी आइलिक क्रेस्ट के साथ, although there are facets available, but they are not too much geometrically congruent. ठीक है ना, तो जो आर्टिकुलर सरफेसेस होती हैं वहां पे, they are not geometrically congruent surfaces. तो वो स्टेबिलिटी प्रोवाइड करती है, बट क्योंकि कॉन्ग्रुएंसी नहीं होती है, तो बिकॉज ऑफ लेसर ज्योमेट्रिकल कॉन्ग्रुएंसी, द स्टेबिलिटी प्रोवाइडेड बाय द आर्टिकुलर स्ट्रक्चर्स इज वेरी लो. So in this case, we require other structures which could be contractile also, which could be non-contractile also. We require those amount of structures to maintain stability over here. क्योंकि अगर stability नहीं होगी तो खाली रखा हुआ तो गिर जाएगा ये तो, ठीक है ना, डिसलोकेट होता रहेगा बार बार. So in this case, we require contractile elements also, non-contractile elements. Non-contractile elements में आपके आते हैं आर्टिकुलर कार्टिलेज, कैप्सूल, लिगामेंट्स, जिनकी हमने आज बात की थी. Contractile elements में आती है muscles. Muscles can be of two varieties. One which are related quite close to the joint, which has lesser momentum and act basically for stability, right? तो और दूसरी muscles होती है which are located quite superiorly. If they are located quite superiorly, they have larger momentum. If they have larger momentum, the torque generated by those muscles will also be larger, so they will be better mobilizers. But here we have more of stabilizer muscles for the SI joint. That comes under the force closure, right? So the geometrical stability comes under the form closure part, and the forces generated by the soft tissue comes under the force closure part. I think I'm quite clear to you people. Okay, if you have any more questions. Okay, as both lumbar and cervical spine have physiological lordosis, but in cervical spine we have more focus on strengthening the flexors, while in lumbar we strengthen extensors. Why is it? No, we do not strengthen extensors. Where do we do that? क्योंकि फिजियोलॉजिकली ऑलरेडी बहुत सारा स्पैज्म प्रेजेंट होता है इरेक्टर स्पाइने में, तो करना ही नहीं चाहिए आपको इस इरेक्टर स्पाइने का. ऑन द कॉन्ट्ररी, यू कैन स्ट्रेंथन ग्लूटियस मैक्सिमस, you can strengthen multifidus muscle, which can in fact provide stability to the joint, right? So abdominals को तो आपको यहाँ पे भी strengthen करना पड़ता है, right? You always, all those people who have increased lumbar lordosis require extensive strengthening for your transverse abdominals. It is not a good idea to strengthen your erector spinae क्योंकि रेक्टल स्पाइन ऑलरेडी प्रोट्रैक्टिव स्पैज्म में होती है, और हम भाई अगर मैं अपराइट पोजीशन में खड़ा हूं तो इट इज ऑलवेज लाइक दैट माय इरेक्टर स्पाइन वुड वर्क. There can't be situations when the erector spine is not working and I'm walking. Okay, I cannot walk or I cannot stand without the work of erector spine. Okay, so we have equal importance of strengthening of your abdominal muscles. Okay, and the deeper located extensor muscles such as rotator longus brevis and your multifidus muscles also. Thank you so much for such wonderful reviews. So if you have any more questions, I'll be there. Otherwise, we shall switch off the session. So do we have any more questions? Any more questions coming up here? All right. Thank you so much. If you have any more questions, you can always talk to me on any sort of social media available. You can just text me. You can just text me on WhatsApp, Telegram. You can write to me on email. You can write to me on Facebook, Instagram, anywhere you want. You can write to. Okay. Thank you so much. Stay tuned for the coming ventures. I really tell you that there are important ventures which are coming here, right? So thank you so much for staying with us. We'll catch you later in the next week.